welcome to Chapter 19. Here we will discuss postoperative nursing management. This starts in your text on page 440. When we look at nursing management in PACU, the most important thing is to understand what is PACU and how we as nurses manage the patient. Of course, PACU is a place where your patient will come after they have gone to surgery. Most importantly, you want to make sure as the nurse in the PACU that your patient is safe, and we want to look at airway. Of course, following our ABCs and going through that frequent head-to-toe assessment. Most of the time, patients will be in the PACU area for 2 to 4 hours, depending on the type of surgery that they have had. You want to make sure the positioning for your patient is correct. Make sure that he or she is not laying on any tubes or drains. Make sure that their pain medication and orders are correct. You want to verify that with the OR circulating nurse who gives you a report prior to your patient being transferred into that PACU unit. You want to make sure that their airway is patent. If they have anesthesia for most surgeries, if it is general, know that their level of consciousness may be delayed. So you may have to check that every 15 minutes for at least an hour. And then you may do assessments every 30 minutes for an hour, and then so on and so forth. You'll do it every hour for 4 hours, depending on how long the patient is in the PACU with you. Of course, make sure you have oxygen available for that airway if they start to decline. Most PACUs will hook up their patients to a pulse ox. This will monitor the oxygen saturation. And as discussed in class, if your patient is in the 90s, and I do mean low 90s, that means 90, 91, 92, and they just came out of surgery, most oftentimes you as the nurse can make a judgment call and place them on 2 liters of oxygen via nasal cannula. So with that said, the oxygen saturation should increase. Now I know we also discussed teaching the patient about coughing and deep breathing. This is a viable tool, but if they're just coming out of surgery, that assessment and that education may not be the best time. Your patient may be lacking when it comes to being alert and oriented and able to follow directions. When looking at the actual post-anesthesia care unit, in your text you can refer to figure 19-3, and that is in your text on page 445, and it respiration. Make sure they have a patent airway. Of course, other important things to look at is their level of consciousness, again, their O2 saturation, and activity, especially if they've had any upper or lower body surgery. Make sure they can move their arms and legs, and this will talk about the anesthesia part of it and them being able to move their extremities. So, more importantly, you want to know all of this during report. You should know if your patient is alert and oriented, if their level of consciousness is decreased. You need to know what kind of pain medications they're on. You need to know, of course, what was the surgical procedure, any allergies. These things are very important. Of course, your PACU environment, usually it is open. If you are able to see it or go into your PACU units when you're on your clinical rotations, this will be a good experience to see. But it is usually open. You can picture an ER type setting. It usually has 8 to 12 beds depending on the hospital facility and how many ORs are operating at the same time. The beds are usually comfortable. They're switched out with the OR beds, because if you've ever been in the OR, you know those beds are like little cots. So they're switched over to a hospital bed. And then, of course, there are 3 phases to the PACU unit. Now, briefly looking at the responsibilities of the PACU nurse, of course, as I stated previously, review that pertinent information with your OR circulating nurse prior to them bringing the patient over. Usually, they may give report over the phone in the OR, or they will give you, as the PACU nurse, report at the bedside so that you, as the nurse, can actually put eyes on the patient and go basically through a quick head-to-toe assessment of the patient with the OR nurse. You want to know any drains, especially your JP drains, any wound vacs that they may have on, any dressings that they may have on, the operative site. Of course, you want to look at that and inspect for bleeding. You want to look and make sure they have on SCDs, or those sequential compression devices for the pulmonary embolisms, and DVTs. You want to make sure of that. You want to go ahead and listen to those lungs, especially if they had any kind of lung surgery. If they have any kind of chest tubes or drainage, you want to make sure you look at that. Make sure all your IV lines, especially if they have multiple lines, make sure they're patent. Make sure they're running correctly. Make sure they're not infiltrated. You want to make sure you're looking at the patient's vital signs. That goes back to those ABCs, checking that airway, checking the breathing, and of course circulation. So make sure that patient's blood is pumping through all parts of the body. And again, you will be checking this patient frequently, every 15 minutes, especially for the first hour. Things can change drastically within an hour after the patient comes to your PACU unit. Of course, you want to get that report, and you can refer to chart 19-1, which is in your text on page 441, which goes over that nurse-to-nurse report and what pertinent things you want to ask. When looking at maintaining that airway, this is your utmost important thing that you want to do. You want to maintain ventilation and oxygenation. That is your primary objective in that immediate post-operative period. Because if we don't have proper ventilation, everything else can go downhill very fast. Of course, we want to prevent hypoxemia, and we want to prevent hypercapnia. Your hypoxemia, of course, is that reduced oxygen in the blood, and hypercapnia is that excess carbon dioxide in the blood. So, of course, you want to know that both of those can occur if the airway is obstructed and they cannot breathe. If their ventilation at any point is reduced, they are at risk for those 2 things. We do not want the patient hypoventilating. Okay, if you're checking those oxygen saturations and they're 89, 90, go ahead and throw 2 liters of O2 on that patient. It will not hurt, especially immediately post-op. Okay, you want to elevate that head of the bed. Some people have trouble breathing when they're flat on their back, unless it is contraindicated. Elevate that head of the bed at least 15 to 30 degrees. Of course, make sure you have some suctioning at the bedside. So your most important things you should have at your bedside when it comes to ventilation, of course, oxygen. Make sure it's working before your patient actually gets there. You want to also have suctioning. Have the suctioning equipment there. Make sure you have everything connected and make sure that it is working. Because if that patient vomits or they start having excess secretions and you have not checked your equipment, things can go very bad very quickly if that occurs. Here's a true or false statement in regarding to the primary goal immediately post-op. And here's the answer with the rationale. Here in this illustration, illustration, which is also found in your text on page 442. It goes over that head lift jaw tilt positioning. And you may remember this from CPR. You want to get that tongue out of the way, okay? So we want to basically lift the head and tilt that jaw. That will open that airway. You need that airway open, especially if your respiratory therapist has to come in and they have to intubate. You want to also make sure that your patient does know if they were intubated within surgery, they will have some soreness when they wake up. They may have a little trouble swallowing. So you want to start with some ice chips. Those are things that you want to educate your patient about prior to them going to surgery. Because when they wake up, they're going to feel like, what's going on with my throat? It's very sore and scratchy. And it is all because they were intubated during surgery to keep their airway open. So again, the head lift jaw tilt position that opens your airway, and you can practice on not really yourselves, but practice on a friend. And if they are completely relaxed, you will see how the structures within the mouth move out of the way when you do this positioning. Again, this is important when you have a patient with dentures as well. This is why they are not able to have their dentures in surgery. Because of this, they may slip out and then block the patient's airway. So we want to protect that airway. The use of oral airway, no, of course, do not remove the oral airway until evidence of the gag reflex returns. So what this is basically saying is when you have an airway placed in your patient's mouth or within your patient, period, they start to wake the patient up prior to them leaving the OR. And they do not take that airway out until that patient is somewhat awake, and their gag reflex will kick in, that there is something foreign there that they are trying to cough up. So it will elicit that reflex, and they will either try to cough it up or they will try to pull it out. Well, of course, as you know, in surgery, they are strapped down to the table. So, of course, they cannot pull anything out, but it will elicit that coughing, as in they're choking, but they feel something in their throat. So it elicits that reflex. And that figure is also shown to you in your text on page 442. The next thing you want to look at is maintaining that cardiac stability. Of course, you want to monitor any indicators of cardiovascular status, and usually as nurses, we get this information during pre-admission testing. If the patient has any cardiovascular defects or disorders, you want to, of course, assess all IV lines. You don't want your fluids going in too fast, but then again, you don't want them going in too slow. Usually you want to look at your orders from your physician and see what it is that your patient is getting and how fast it is going, or your rate that it is running at. And also, you want to make sure if your patient does have cardiac problems, the amount of fluid that they're getting should be congruent with their cardiac condition. If you have a patient in congestive heart failure, you would not want them on a lot of fluids after surgery. So, with your normal healthy adult patient that has no cardiovascular issues, their fluids may be running at 150 an hour versus your patient that has, let's see, any kind of cardiovascular defect, or let's say if your patient has atrial septal defect, and this can go into adulthood. So if they have a defect of the heart and it is not allowing that heart to pump as sufficiently as it should, then your patient can go into fluid overload. We do not want our patients going down that road. So you want to monitor your IV fluids, and it all links together. So everything is not separate when it comes to patient care. It all has to link together. So you want to check things simultaneously and how they can link together. You want to also monitor that blood pressure. Your patient is at risk for hypotension after surgery. So those are things you want to look for. Hemorrhage is another big thing that you want to also look for. Now, although it is uncommon, it is serious, as we talked about before. Hemorrhage is an emergency. Do not treat it as if, oh, they're bleeding just a little bit. It's fine, we'll change the dressing. If there's a bleed, there's a difference between a spot of blood and your whole dressing being saturated. As novice nurses, you may not understand the concepts of, oh, this patient is bleeding. Think about the signs and symptoms of hemorrhage. How will your patient look? If they're coming right out of surgery and they've had general anesthesia, they may be hypotensive, their respirations may be decreased, their urine output may be low. Let's see, what else? Their temperature may be a little elevated, or it may be a little low. So, can any of those be impacted by a hemorrhage? Yes. So you can't necessarily say, oh, my patient's tachycardic and, they have low blood pressure, but that's just because they just came out of surgery. That could not be the case. Your patient could be bleeding internally. If you're checking, let's say, the abdomen and they've had abdominal surgery, you may not hear any bowel sounds when you're auscultating. But when you're palpating, you may say that the stomach is very firm. Go with your gut instinct and never be afraid to ask for a second opinion of another nurse. If you're unsure, please ask for another opinion. There's usually 2 to 4 PACU nurses in the unit, depending on how big the unit is. So if you think, even with an inkling of thought, that your patient may be bleeding, please get a second opinion. If your patient is alert and awake, they may be disoriented, they may be restless, and they may be pale. Those are obvious signs that you may think, oh, hemorrhage, they just came out of surgery. But you may think that this is the normal part of the post-operative period. Don't assume that things are normal just because they are coming out of post-op or that they're coming out of surgery. You want to check your patient thoroughly and follow that gut instinct, especially when we look at hemorrhage. If it is serious, sometimes your patients have to be taken back to the OR. You can look at table 19-1, which is in your text on 443, which goes over the classification of hemorrhage. When looking at outpatient surgery and direct discharge, of course, when does your discharge planning start? It starts prior to your patient even coming in to get the surgery. Usually we go through pre-admission testing and we start that discharge process right then. We start that education right then. Because if we're doing outpatient surgery, when are we actually going to see our patient? The day of surgery. We may not see that patient face to face until they come in at 5:30, 6 o'clock, 7 o'clock a.m. the day of surgery. So that is the first time we've laid our eyes on the patient. But in the preceding weeks, we need to be talking to that patient, getting those labs done, talking with the family members if it's going to be some kind of surgery that they need help when they go home. We need to make sure that the family members and the patient understand what's going to happen. And then, of course, we want to do a discharge assessment to make sure that the patient is actually ready to go home. We can't send the patient home if their level of consciousness is still decreased 2 hours after post-op, if they cannot move their lower extremities, if they're having signs and symptoms of bleeding. We cannot just send the patient home just because, let's say, their 2 to 3 hours in PACU is up. We can't just kick them out. So we have to do a thorough assessment. Of course, you're going to provide that written education. You're going to give them verbal education. After surgery, they may not understand or comprehend a whole lot of your verbal instructions. Make sure your patient is alert. If your patient is not alert and awake enough to, be coherent to understand what's going on, make sure there's a family member there that will help the patient, and make sure that they're following directions and looking for any of those complications when they're home. If they do have a wound, make sure you teach both the patient and their caregiver or family member how to care for that wound, especially if they have to do dressing changes. A lot of times, the most common question that comes up is, can I shower? And if I shower, can I get this wet? And if it gets wet, what do I do with it? Well, some physicians may say, do not shower for 3 days. You can kind of take a sponge bath, but I don't want you immersed in water. I don't want your incision getting wet. Some, depending on where the incision is, you can cover it and then shower. So it just depends, and we have to tweak that educational portion to the patient. So of course you want to give them their prescriptions prior to discharge. Some hospitals will call in the medications before the patient has gone home, and they actually get their prescriptions right there. So you want to know the differences from the patient that will leave your PACU unit and go to the floor, or to your regular med-surg or ortho or surgical oncology floor, versus your outpatient that will come in for surgery, stay a couple hours, and go home. Of course, as I said before, give instructions to the patient or a responsible adult who will accompany that patient, because not all the time your patient will be able to comprehend all these instructions. Hence why we start the discharge plan prior to the patient even coming in, so that we don't bombard the patient or the family members with all of these instructions and everything when time to go. Of course, patients are not to drive home or be discharged home alone, especially after a surgery. So we do have to have a responsible adult accompany them. Note that any sedation, any anesthesia can cloud their memory. So they may be a little confused, they may be a little out of it. That is normal. If they prolong this, and I mean if they're, still have cloudy memory, their judgment is impaired, they're not able to do the things that they did prior to going to surgery, and this lasts more than 24 to 48 hours, then that would be a complication. And the responsible adult with them needs to know that and who to call in case that does occur. If we do not teach them these things, they will go home thinking that a lot of this stuff is normal. So when we look at indicators of hypovolemic shock, one of the things that you want to know as the PACU nurse is what to assess for. Although you're assessing your patient every 15 minutes, you may miss some of these things or think that there's something else going on. So you want to rule out things, and these are indicators of hypovolemic shock. But what you want to think of as the nurse is what to do if you do notice these things. The primary intervention for this is fluid volume replacement. Okay? So you want to replace that volume that your patient is losing. You want to also know that usually, depending on the surgery, it may be more, that most surgeries will lose up to 500 mLs of blood. during the surgery. So you also want to note that they don't necessarily have to have PRBCs or your packed red blood cells to replace them that they've lost. They just need fluid replacement. So hence why your patient is on IV fluids. Hence why we need to check these IV lines. But if your patient has been losing more blood, especially in your bigger operations, if they've lost 1,000 mLs of blood or even 12 to 1,500 mLs of blood, and let's say they got 1 unit of packed red blood cells in the OR, we as PACU nurses still need to check diligently for that hypovolemic shock and hemorrhage. So, looking at those indicators of hypovolemic shock, you want to know if your patient is tachypnic. Those are those rapid respirations. If your patient has that weak, thready pulse, if their blood pressure is going down instead of going up, those are red flags. So we want to replace that volume. That is your primary intervention. Usually you will use LR or your lactated ringers or normal saline. They may also introduce blood. They may give blood back to the patient depending on how much they've lost, but we have to replace that volume. So you want to make sure that you have patent IVs. You want to make sure that you're assessing this patient thoroughly every 15 minutes, at least for that first hour, to check for these things that can occur. Make sure you have oxygen available, especially if something like shock is occurring. Another thing that I do want to point out when we talk about blood pressure, because this can be a little tricky. Of course, if your blood pressure is decreasing, that's an ominous sign, but you want to note the patient's baseline blood pressure. So if your patient's blood pressure is, let's see, 90/55, and then they come back from surgery and their blood pressure is 87/51, would you be concerned? My answer to that I would not be as much concerned about that drop as to if my patient's baseline blood pressure was 140/80 and now it's 87/51. That would be a red flag to me. So you just have to look at and compare your patient's baseline with, what's going on at that point in time. So use nursing judgment, but you also want to look at your patient's history. When looking at relieving pain and anxiety, of course, we want to relieve the patient's pain. You also want to note that it may not, or shall I say, their pain may not go completely away. So you do want to educate them on that and a acceptable pain level that they are able to tolerate. But we do want to have and make them comfortable. Of course, after surgery, we place them in a quiet, noise-free environment. If you've ever gone into PACU, you see that it is very quiet, it is very tranquil, the lights are usually dimmed, there's not much going on in there. It is not like, your med-surg units, your ER, and those types of units where everything's fast-paced, everything's, loud and crazy, and you hear bells and sirens and everything. It is not like that in your PACU area. So, you want to administer any pain medications that the physician has ordered, whether it be via epidural. They may have changed the epidural medication. If it is IV medication, those are your short-acting ones. They can give morphine, Dilaudid, fentanyl, things like that. So you want to look and make sure of your orders and make sure that your patient doesn't have any allergies as well, because sometimes your physicians may switch from IV pain medications to PO medications, and your patient may have a slight allergy to what they prescribe PO. So you want to check that as well when you are medicating your patients. Here, looking at controlling that nausea and vomiting, this is usually an expectation after surgery of any type. You want to control that nausea before it gets to the vomiting stage. Okay? The first indication of nausea, when your patient says they do not feel good, go ahead and give them something for nausea. They may have Phenergan, they may have Zofran, IV. You want to make sure you give that to your patient when they tell you they're feeling nauseous, okay? Do not wait until they vomit. We want to stop the patient or prevent the patient from vomiting just because it puts pressure on their surgical site, no matter where it is. So, and it creates more pain. So we want to prevent that vomiting. And this is one of the things we treat prophylactically. So if we're giving patients pain medication and we know they haven't had anything to eat, they may give Zofran or Phenergan right away versus waiting to see, oh, let me see how, the pain medication works and see if the patient gets nauseous. Don't wait for that. You can treat it prophylactically. Here's a true or false statement in regards to the most important nursing intervention when vomiting. And the answer is true, and the rationale is there. Now, when looking at our gerontologic considerations and our elderly population, of course, we want to always note their differences. Of course, they have decreased everything basically. So we want to look at the dosages of medications that they're getting, the amount of hydration that we're giving them. We do not want to send these patients into fluid overload. We do not want to overdose them on anesthesia and place them in a coma. Of course, you want to educate the patient and their family on the post-operative delirium that may occur. You want to let them know that the patient can be treated with medications and that it will return, or they will return to their normal state of being. Do not just, play it down and say that, the patient is fine and they'll be fine, don't worry about it. The family is concerned, so you want to educate them that this post-operative confusion and delirium is a part of this population, that this can occur, and that we can treat this, and that the patient should return to a normal state of mind after the anesthesia has left the body. Of course, you can reorient the patient as needed, and again, with the pain, we want to make sure we're giving them adequate doses without overdosing them. Looking a little bit at wound healing, we won't spend too much time on this. I just want to point out a couple of things here. There is a diagram in your text on page 452, which is chart 19-4. It goes over the healing mechanisms, and we'll look at first intention, second intention, and third intention. So with first intention, this is your normal surgery that has occurred. They did a normal incision, they stitched it up, it has healed fine, there's little tissue destruction, little scar formation, nothing's really going on. We like these. We want our first intention wound healing. When we look at our second intention wound healing, those are those wounds that got infected, or those surgical sites that got infected, or when we think about abscesses that form and your patients come in with abscesses. If your doctor or surgeon does an incision and drainage, then you want to know that those cells are still going into that open wound, and most of the time they will pack that wound. And so when they do finally pull it out and they stitch that together, the repair is referred to as healing by granulation. So there may be pus that has formed and things of that nature. And when we look at it post-operatively, we will see that that wound has been packed and usually sealed. And they may leave that dressing on there with that for a day to 3 to 5 days, depending on the type of wound it was and what they actually had to do. Now, the third intention wound healing that we look at, this is also known as the secondary suture. It's used for those deeper wounds that have either not been sutured or they break down and they need to be resutured later. So you bring together those two granulated surfaces. Here's a question in regards to the inflammatory stage of wound healing. And here's the answer with the rationale. Now, when we look at the types of surgical drains, you may run into a few of these, with the most common one being the JP drain. And you may see these with your surgical patients, especially those that have had a lot of fluid loss, or they may have had an abscess growing inside that the doctor wants to drain that fluid. So we want to look at all three of those, but you want to pay attention to what you need to do with these drains. This is important to get report on when you're getting your patient in PACU. If they have a drain, as you know, why they had that. The drain is usually there to let those fluids out. Of course, there's the Hemovac. You may see that one around as well, and the Penrose drain. The two most common that I have seen is the Hemovac and the JP drain. If you are unaware of how to drain the bulbs or these drainage systems, please do ask another nurse to show you, so that you are aware of how to drain it, how to cap it so that it is properly draining, and to see how it is secured inside the patient. You don't want the patient pulling it out, and you as the nurse shouldn't be pulling it out as well, especially not, unintentionally. So you want to know, how much draining the patient is per hour. This is part of your intake and output when you're documenting. You want to also note if there's any bloody drainage on the actual dressing itself. If there's a little spotting, that is normal. If it is excessive, you want to let the surgeon know. Do not be afraid to call your surgeon and say, hey, I believe my dressing is bleeding. They may tell you to mark the spot with a permanent marker and see if it is spreading. That is a good indicator to see if the patient is actively bleeding. If it starts off at a spot on, let's say, a 4x4 gauze dressing, and an hour later it's now half saturated, or even if we won't go that extreme. Even if you've drawn a little circle around the spot and then an hour later it has grown into 3 to 4 centimeters on the gauze, that is an important finding, and you want to let the surgeon know immediately. Looking at the purpose of those post-operative dressings, of course, they are to promote that healing. You want to absorb any drainage. Again, if you're having spotting or drainage, that is okay. We do not want excessive spotting or drainage. You want to teach the patient how to split and or immobilize. These dressings can be anywhere from a pressure dressing. It could be something light like a 4x4 gauze. It can be an abdominal pad with some paper tape. So you may see different types of dressings. You want to know how to protect that dressing. Can the patient get it wet? Can they, take it off? When does it need to be changed? You need to know all of these things. Even if the patient is in your post-operative area and they are then being discharged home, these are things you need to teach the patient as well. Again, looking at changing that post-op dressing, usually that first dressing, if it requires to be changed, is changed by the surgeon themselves. They want to see, the drainage on the pad. They want to look at the patient's incision because they know how they left the patient, and what they did to the patient. So then they can assess, oh, well, is the wound actually healing? Do I need to put another dressing on? What types of material? There are different types of dressings. So you want to make sure you know what type your patient has. If they require a sterile dressing change versus a clean dressing change or a non-sterile, you need to know how often you're assessing that wound. If you're assessing it every 15 minutes, if you're assessing it every 8 hours, you need to know these things. You need to be able to report these things to the nurse. If your patient is going up to the unit, let's say a med-surg unit, if your patient is going up there, you need to be able to report these things to them. You need to teach the patient about the dressing as well. And of course, most importantly, document. If you do not document anything about this dressing, we don't know that the patient even has a dressing. If you don't document anything about the drainage that you see on the dressing, we don't know when this drainage started. We don't know, if it has progressed or if it has decreased. So please, please, please document your findings. Looking at some of the complications that can occur, of course, most importantly, as I can state over and over and over again, please assess your patient's airway and respiration. You want to make sure they have an effective airway and ventilation. Checking them every 15 minutes for that first hour at least. You are going to be checking those respirations, checking and making sure they're not shallow and that, they're above 12. And if they're not above 12, what is your protocol? You need to be checking those vital signs, making sure we're looking for, that hypotension. We're looking for that increased heart rate. We don't want our patients to go into shock. We want to check those pulses. We want to check that blood pressure, okay? Those are things you want to check. You do not want your patient to have hypovolemic shock or hemorrhage. Those are two big things right after surgery that we look for. And of course, you want to assess your pain, especially if your patient is alert and oriented. You want to be proactive in assessing and medicating your patient for pain. Here, you will find some of the nursing diagnoses that are applicable to your patients in the post-op areas. Again, here's a few more nursing diagnoses that would be pertinent for your post-op patient. Now looking at some collaborative problems. These are problems that can occur post-operatively that we as nurses, whether or not we're in the PACU with the patient or on the med-surg floor with the patient, these are things that we need to look for. Of course, we went over hemorrhage. That is one of the biggest things that we look for post-op. Another one that we look for that is very important is wound dehiscence. How often are we checking that wound? If your patient has a stomach wound, we need to teach them how to splint when they're coughing and deep breathing. So you want to check on these things. You want to check if the patient has a hematoma. If they are, let's say they had, we'll say they have some type of vaginal surgery, and the surgeon said to expect some bleeding. Well, when you check that perineal or vaginal area, you may notice a large lump, and it is soft. Okay, most of the time your hematomas won't be hard. They are soft, they are palpable. What can you do as the nurse for a hematoma? Are you gonna send your patient back to the OR and drain it? Not necessarily. They may tell you to put some ice on it and you see if the swelling goes down. Usually your hematomas will reabsorb. If your patient is hemorrhaging, it may create a hematoma. Then we may have to intervene. You have to err on the side of caution and thoroughly check your patient. Same thing with our pulmonary embolisms and our deep vein thrombosis. How can we prevent these? Teaching about those coughing and deep breathing exercises. Teach patients to get up and get out of bed and start moving. If they're not getting up out of bed, we need to throw on some SCDs or some anti-embolytic stockings. Those are things that we as nurses have to do for our patients in this post-op time. Pulmonary infection and hypoxia. Same thing. We're teaching about that incentive spirometer way before they get to the hospital, way before they go into surgery. We're doing that on pre-admission testing. We're making them demonstrate to us how to use that incentive spirometer so that they use it correctly. So those are things that we are looking for and assessing for, and those are also things that we have to educate our patients. And lastly, here's a picture of a wound dehiscence or evisceration. Your wound dehiscence, it's coming, your wound actually starts to open. And the best way I can describe this, or what I want to tell you about it, you may see that the wound starts to open on one end if they haven't glued it properly, or if your patient is excessively coughing, or if your patient is obese. And this is when we have to really, really evaluate the wound. Evisceration is when it actually, your bowel actually starts coming out of that wound. So you want to know the difference between the two, and what do you do if this starts to happen? Besides freak out, usually they want to have you put an abdominal binder on the patient, put a sterile dressing on the patient, and the surgeon needs to be notified immediately if you do notice this start to happen. And with that said, that will conclude Chapter 19, Postoperative Nursing Management.